I happen to be one of the very fortunate people with MS, actually. I was diagnosed 10 years ago, and really truly was a train wreck happening. Lost my eyesight, my bladder, my gait was off, everything. It's now invisible for me, although I'm on injectable drugs that I seem to have responded to very well. So where does this fit for someone? Is it something that I should consider when we're considering tracking my future? It's a question I'm asked often by my children, who are more aware of the recent therapies and everything out there, because they saw the worst and they see me now. They don't ever want to go back.
Are you willing to share what you're on?
Rebif.
Okay. The interferons, as I mentioned earlier, in some of us change the blood-brain barrier, okay, and maybe make it a little less leaky. But the 10-year data, almost all the data that we did on those drugs, the crab drugs, was done on MRIs, and less lesions in the brain if you were on drug. But we've known for years now how your MRI is a very poor reflection of how you're doing clinically. Okay? So that's one part. The second part is, I would refer people, if they're considering one of the crab drugs, and gosh, they're pushing that pretty hard now. They're going to push the new one even more because it's 48 grand a year, the oral one. I would suggest you look at a study done at the Mayo Clinic 20 years ago. They followed people with MS for 10 years, 100 people. There was one they couldn't find, they moved away and they couldn't, but 99 of them they followed. I think 3/4 of them, none of these people are taking drug. 3/4 of them did superb. They had nothing. They had no problems at all without drugs. I mean, this is a waxing and waning disease. But I've looked at the data, and there's been 3 reviews now on the Rebifs and the rest of the inventions of the world. I think you're doing well all by yourself, and I would suggest the drug's not a huge factor. I'm going to be really blunt. I think it behooves you to find out if you have CCSVI. And so I would go to an excellent clinic, really good at echo color Doppler, or I would have an MRI, MRV under the Hakey protocol. One of those two things. And why am I suggesting that? Because you have children. And sooner is better. You can still keep taking your Rebif if you believe in it. There is a few that do. I would really be reluctant if people stayed on Tisabrin. The interferons still have some side effect. You get more malignant melanoma, and you get more cancers. It's an immune system suppressant. I'll be really honest. They don't have 0 long-term side effects. But it behooves you to find out if you have it. Because if you do, then eventually we'll get there when we've got this little blood pressure unit on your neck with seismograph to test it. Because our kids need to be tested ahead of time. And we need to know that. So you've got time to make all your decisions because you're doing great. And more power to you. And that's what slowed me down. My MS was invisible. Okay? But if you can sit there comfortably and say you have 0 fatigue and 0 cognitive challenge and 0 bladder problems or bladder infections, okay, I'm with you. You're perfect. Stay there. But spend some time thinking about it. You're lucky. You can sit and watch and wait and see. And within a decade, we'll have it here. I don't know how soon. So, but I would think about getting it checked when it can truly happen, or follow the information on the seismograph so we can get that simple test, which will be done relatively easily, and wait and watch and see. But for anybody that's on the other side of the coin, the really severely affected, or the moderately affected, or the unable to work, or the worried about dementia group. Get at it. It's a big piece of the puzzle. It's not the only piece. I mean, I still stay off gluten, and I can't believe the number of people that are getting on board now. They have their treatment, they're quite a bit better, and now they're willing to go the extra mile. This is an individual journey. We get to decide how we do. It's a chronic illness. We've got time to play around with it. Some of us got more time than others. And the pieces of the puzzle, the more we can get working, the better. So, I'm not trying to put rain on your parade now. I really am not. I'm just delighted you're doing so well, and I've seen people do well for a long time. Some of them 20, 30 years. So, may the force continue to be with you.
Okay, before I ask my question, I'd like to speak to the lady who was saying she's doing well. Most of us started off relapsing, remitting, but I know at my next neurologist appointment, he's told me to bring my husband with me, so he's going to tell me that I'm now secondary progressive. My 8-year-old daughter says, I'm still the best mommy in the world even though I can't do anything with her. I don't want you to have to deal with that because that breaks your heart. So get yourself tested as soon as you can. And if you have CCSVI, get yourself treated before you get to that point. Now my question for Dr. Code is regarding, because I know that we can't get follow-up care here, but because I'm going secondary progressive, I don't want to have to wait until it's made available here in Canada, because it could take these jerks another 10 years because they got their heads so far up where the sun don't shine. But my question is, because with the follow-up care, I mean, Mostic, he actually died because he was denied follow-up care. So he had to go back to Costa Rica. And I mean, I don't want that to happen to me either. What can we do to push to get that follow-up care here?
It's going to raise the profile a lot. Us being together today, being on 2 television programs tonight on the news. It's all about awareness. And once people become knowledgeable, and there's enough groundswell that it'll change. I didn't idly suggest Ralph Klein should get treated for this. Because if he got treated and did well, he'd tell us about it. Because he's known as a straight shooter. So, the follow-up care, it's useful. You can get it if you need to. You can get an ultrasound done in Calgary. What are you most urgent about? The best indication that you need some follow-up care is your symptoms recur. Don't phone them overnight, because you may end up with a bladder infection, maybe things haven't all resolved there, you've got a rough cold. Wait a week or two and see if there's something else there that may be triggering this relapse or this worsening of symptoms. But failing that, then start to get back in touch. Urgent follow-up care because you're clotting in the neck. Okay? And I get 2 or 3 phone calls or emails a week from anywhere in Canada. Anywhere. People get clotting of their jugular vein. Don't panic. You're still getting blood flow. It's still getting out of the brain. Most of the ones that clot were really small to work with, and they're more at risk of clotting, perhaps. We're starting to find out there may be a small set of us have something called Hughes syndrome, and that means we've got excess clotability. You've heard of maybe Leiden or factor V deficiency. These are people that are super clotable. You put someone with Leiden deficiency in the population on the birth control pill, they have a deep venous thrombosis in their leg, or a pulmonary embolus. Okay? Hughes syndrome is a little bit along the same idea that happens. Treatment for Mr. Mostic was he had a clot in his jugular vein, but he insisted on a stent, and it was the first stent that the fellow had put in Costa Rica, but it clotted off. He was relatively panicked. The emergency room, I hope they got their backside suit off, denied seeing him in Ontario, Southern Ontario. He went back. I spoke to people about this that spoke directly with his, vascular surgeon. And I thought initially that he'd got the so-called clot-busting drug, which we use in Canada for heart attacks and strokes, TPA, that he'd got perhaps too much of it, and he bled to death inside. Because he did bleed to death inside. We have people bleed to death inside from clot-busting drug every year, a few. Because it's a recognized side effect when you try and stop the heart attack or stop the stroke. And we do it in all hospitals, and it's done here in Alberta, right here in Edmonton. We still lose people. But it turns out he did not have an overdose of the entity, but he had a very adverse reaction to it. And we can get an allergic reaction. If he'd been carefully seen by any sensible stroke neurologist or vascular surgeon in Canada, they would have said, yes, you've got some clotting in this vein. We're going to put you on oral warfarin and or Pradax, and whatever combination that they use. And treatment in Canada for that clot, same as it is for deep venous thrombosis, except we put them on bed rest so they don't get a big one up to their lungs. This isn't going to be a factor if it goes to your lungs. You're not going to die of a pulmonary embolus from a vein this size. All we're going to do is put people on those medications and wait and watch and see. There is no urgency. But he couldn't know that, and the doc there was trying to do things relatively quickly because he would have had to pay a lot per day for his hospital care. And he had an adverse reaction to the drug. We still lose people in anesthesia. It used to be 1 in 10,000, now it's maybe 1 in 50. But people still die from an adverse reaction to a drug. So his was not due to lack of activity, it was lack of knowledge in the medical community that mistreated him. I had a retesting at 3 months, and I retested my iron because I wanted to see where I'm going, because I use myself as a test case, you know, in the whole scenario. I didn't lose any sleep about not having an ultrasound at 1 month. Okay, I had the equivalent at 3 months. There's nothing magical about the ultrasound, because if you're doing well and you're not having recurrence of symptoms, you're doing well. There is no reason for it. So, follow-up care, it's not near as big a deal as we've made it. The ones who've hoodwinked into saying that we need to do it are the neurologists working on the surgical principle. If you do a procedure, you must follow up that person with their complications. Serious complications from this virtually don't happen. They are not life-threatening. Relax. But we wind ourselves up. And we're pushing against a wall of resistance, so we push harder. And I don't blame us for doing that. But breathe deep and stay calm. So it's not as big a deal as follow-up care. The ones that are hoodwinking into us are the local medical community who are trying to fearmonger us. We need not be fearmongered on this, folks. This is a safe procedure, and the likelihood of any issue immediately occurring is almost a non-entity. And I'd be happy if David or if Joseph wants to make any further comment.
I would just add one thing. You know, whether you come to see us or whoever you go to see, if you're going to do it, get it done as best as possible the first time. Because if you have a bad angioplasty, or if you have a bad, a stent or something wrong the first time, the ability for us to recover your ability to its maximal extent is severely reduced. So do it right the first time. That's what I would say to you. Doing it right the first time, in my mind, is perhaps the most important component of avoiding complications down the line.